Hi there. My name is Erin. I think you all know of me as Mr. Henning's partner, but also in my day life, I'm a public health researcher. Largely, I focus on sexual and reproductive health issues. So when I was told you all were doing contemporary issues, um, I thought it would be interesting and important to do a lecture on the Patient Protection and Affordable Care Act, otherwise known as Obamacare or the ACA. This is a piece of legislation um, that is pretty huge and is also highly controversial. Was a focus of the campaign season, and we're still hearing about. So what I'd like to do is, as briefly as possible and as clearly as possible, try to sum up some of the basics of it, do a little bit of a primer, um, and provide some background on kind of what's going on. Also, my cat is walking behind me. That's a thing. So I apologize for the video here. So what I'd like to do is just start first by talking about the history of healthcare access and health insurance, how that led to the ACA, and then I want to spend some time on the impact of the ACA on private insurance, then public insurance, and then I want to wrap up with just a couple of other issues that I think are interesting and important and politically relevant. So to begin, if we think about how people access healthcare historically in this country, starting really, early 20th century, moving backwards, it was a pretty standard thing, right? If you got sick, you would call your doctor, you'd see your doctor, they'd do some things, you'd be handed a bill, you would pay him for his services. If you needed medications, you would go to the pharmacist, and you would pay the pharmacist for whatever they gave you, right? Goods exchanged for money, right? Classic. However, as healthcare technologies progressed and as the healthcare system became more complex, this really became kind of an unsustainable system, right? I mean, there's just so many components at play. And this is where really health insurance kicked in as a concept. So health insurance, we're defining as any program that helps pay for medical expenses, whether through privately purchased insurance, social insurance, or a social welfare program funded by the government. So we would consider, for example, the national healthcare system in the UK, we would consider health insurance as well. Okay, all those things are consistent. Um, so in the middle of the century, employer-sponsored health insurance really dramatically expanded. And this was a direct result of wage controls that were imposed by the federal government during World War II. So basically, there was this economic boom. There were lots of jobs, and employers were trying to attract potential employees. But with this cap, they looked for other ways to entice people to join their companies. And one of the things that they came up with are these fringe benefits, as we call them. So things like paid vacation leave, and really health insurance was one of the big ones. So, and this is still the way that most Americans get their health insurance, through their employer. In 2007, for example, and this is before the ACA, some 60% of Americans were covered through an employer. And this is great, right? In part because employers help cover the cost of it for you. So typically, employers pay about 85% of insurance premiums for their employees, and about 75% of their premiums for their employees' dependents. So premiums, just to define the term, because we're going to use it a lot in this talk, is essentially the amount of money that you pay per month or per year to have health insurance for whatever health insurance plan that you have. Those are your premium costs. There are other costs associated with health care and health insurance. We're not going to really talk about any of those, but we are going to talk about premiums a fair amount. Okay, so it's great. So you have your premiums largely covered by your employer. For folks that don't have that access, we know in 2007, only about 9% had individually purchased plans. So people would call up a health insurance company, provide information on themselves and their health history, and individually purchase plans. And while you could have the same benefits, the average out-of-pocket spending is much higher in the individual market, with higher deductibles and other cost-sharing provisions. And we're going to talk about why that is in a minute. So as you can see, I mean, really, the problem with an employer kind of center program is it's really not accessible, or it's less accessible for part-time employees, in small companies, and it creates a system of healthcare access inequity for the unemployed. So we've kind of talked about here, there's about 70% of how people get their insurance. For the other, about 30%, there's a component of those that get their health insurance through public insurance, which we will talk about, and another component that falls into this insurance gap space. I'm sorry, my cat is distracting me. So I will say that the ACA is not the first time in recent history that there has been an attempt to undergo health reform in this country. But it is the first time that it was successful on a national scale. So after much turmoil and much fights in both houses of Congress, the ACA was signed into law in March of 2010 by President Obama. So the ACA really builds on our current healthcare system. It's still largely private and market-driven, but it did include key provisions to make health insurance more accessible and affordable for people. We're going to talk through some of those. And the overall impact has been quite large. They have documented that over 20 million previously uninsured people in the US are now insured. So these are people who did not have access for a number of reasons that we're going to discuss and now do. And the main principle here is one of shared responsibility. So it's partially the responsibility of the insurance companies, partially the responsibility of the government, of employers, and of the individuals. And we're going to talk about how that works. So first we're going to talk about private insurance, like I said. So how do people get private insurance now under the ACA? So again, most people still get their health insurance from their employees. However, before, as I said, it was kind of this benefit that a lot of employers offered, this idea of health insurance, right? However, it wasn't required. Under the ACA, there is now an employer mandate. Firms with 100 or more full-time employees needed to insure at least 70% of their full-time workforce by 2015, and that's risen to 95% in this year. Okay, so big firms need to provide health insurance for their employees. Small businesses between 50 and 99 full-time employees also needed to start insuring their full-time workers this year. So that covers a lot of folks. Small businesses, I'm not going to go into how that works. They don't fall under this mandate. There are other kinds of incentives that are in place to try to get them to offer health insurance for their employees. It's complicated. I'm not going to go into it. But know that there are other kind of incentives there, right? So there are kind of these additional pushes for employers to offer health insurance. Now, for folks who cannot get insurance through their employers or unemployed, whatever, there are these health insurance exchanges, which I'm sure you've heard about, that are generally administered by states. For states that don't want to run them, there are federally facilitated exchanges. And the idea when they were creating these exchanges was to really create something that was easy to access and affordable for people. So they identified two main health insurance barriers for people who are uninsured. One is, of course, this idea of affordability, right? Like talked about, the plans tend to be more expensive for individuals, and that means people less likely to buy insurance. The second is this idea of health insurance literacy, which is that health insurance is really complicated. There's a lot of jargon, there's a lot of terminology. When you're trying to find a plan, looking at what is covered, what is not covered, it gets very complicated very fast. Even for people like me that work in health, it's very complicated. So again, these exchanges were set out to really serve individuals and small employer groups and kind of mitigate these issues. So when it comes to health insurance literacy, they came up with this coding system, essentially, for the market exchange plans. And so they offer now 4 levels of plans: bronze, silver, gold, and platinum, depending on the level of coverage. So basically what this means is a bronze plan will cover 60% of your medical expenses that you accrue within a year, whereas a platinum plan will cover 90%, right? So platinum sounds really good, except for the fact, of course, those plans are going to cost you more money. The premiums are going to be higher because they cover so much more. So that may not be a good choice for someone who's likely not going to use a lot of healthcare services, right? Makes sense. But there's a clear system in place for you to be able to see how much a various plan is going to cover of your health expenses. Now, to deal with affordability, persons whose income falls between 133% and 400% of the federal poverty level are eligible under the ACA, using these exchanges for federal subsidies when they purchase their insurance, on a sliding scale depending on income. So there's financial help to help people buy plans from the marketplace. You may wonder why it's not 0% to 400%, and that's because people under 133% qualify for public insurance. And so we'll talk about that in a minute. So again, this is really targeted towards a small segment of the overall number of privately insured people in our country, which causes some concern. And we're going to talk about why in just a minute. The last thing I just want to mention is that youth now can be covered by their parents' insurance up to the age of 26. So another way that young people can access insurance. This was very much not the case when I was that age. It was the rule as it was when I was that age is at age 18, if you were not in college, or when you graduated college, you were no longer allowed to be on your parents' insurance. So that's a pretty big change. So that's kind of the gist of how you access insurance. So what's the big deal? Where's all the controversy with this in the ACA? So to dive into this, I really need to tease out a couple of concepts. And the first thing I'm going to talk about is experience versus community rating. So bear with me because this is a little bit abstract. And so the rating system refers to how an insurance company decides how much money to charge you for your insurance. Okay. So experience rating says that premiums will reflect individual or group level risk or costs, right? So I'm going to take a minute to say, I should say, insurance companies are for-profit companies, right? They need to make money. They need to not go bankrupt. They need to not go in, lose money based on the healthcare costs and that they are covering for the members of their group, right? So there are ways that they calculate this out and predict how much these costs are going to be for them in order to still maintain a profit. So they set premiums based on that. So in an experience rating program, everyone pays the same premium within a group or by an individual. I should mention that the group we're talking about is really things like employer groups. So it really has to do a lot with employment coverage, or people who are covered through their employer. So for example, I work for the University of California in San Francisco. I get my health insurance through them. That is my health insurance group. The premium rate that I have comes from that group. When I signed up for it, it was just the rate that everyone that works at UCSF gets. And the goal of this arrangement is really to enable groups, really these larger employer groups, to pay less for their insurance because the experience within that group is likely to cost less overall than a community rating group, which includes all other people that are not in the workforce. And we're going to talk about that in a minute. So basically, if we think about it, I'm a young person, healthy enough. I go to the doctor maybe once or twice a year, right? My overall healthcare costs for the insurance company are very low. And there's an expectation in workspaces that there's a lot of people that their groups are made up of a lot of people like that, particularly in professional circles, right? And so they can make estimates as to how much expenditures they're going to have, and thus keep premiums fairly low for people in professional settings. Of course, this varies. So all members of a specific group, like I said, would pay the same premium, but your group's premium would be different from another group's premium. So for example, to talk about this difference in risk and how this impacts cost, a group that is made up of bank executives are likely going to pay a lower premium as a group compared to a group of coal miners. And this is because miners have increased health risks as a result of the nature of their occupation, right? Going into coal mines, there's a lot of health risk associated with that. And thus it would likely cost more to insure them. Like if there's going to be more health expenditures for the insurance company to cover them, as opposed to this group of bankers who don't have the same occupational health risks, right? And so that's how they come up with what the premiums are going to be for these groups. Now, if you are an individual who is not getting their insurance through an employer in this system, they are going to base the cost of your insurance on your overall health profile, right? Your medical profile. So if you have diabetes or have other kinds of chronic conditions, you are likely going to have a higher premium because they are going to try to not lose money on you, essentially, right? So really, in an experience rating system, individuals who aren't getting their insurance through a group really lose out, in particular those that have health issues. So this is counter to a community rating system, which requires health insurance providers to offer insurance policies within a given space, so like within a state, for example, or a city, at the same price to all persons without any knowledge of their health status or regardless of their health status, okay? So this kind of flattens things, right? But the consequence of this system is that people who have less illness, in effect, wind up really subsidizing and support the cost of care for people who have more illness in a given year. So to illustrate this, let's imagine that there is a young runner, someone very healthy and athletic. They're going to pay the same premium as an elderly diabetic within this community rating system. And in effect, because the young healthy runner doesn't use many healthcare services, they would really be subsidizing the cost of care for the elderly person with diabetes who's going to utilize more of those healthcare services. So again, in an experience rating system, you're going to have your young runner here, it's going to have a fairly low premium, and you're going to have the elderly diabetic up here, it's going to pay a much higher premium. In a community rating system, they're going to be flattened out. And so likely, the diabetic's going to pay less, and the healthy runner's going to pay more. Okay, and that's how that plays out. So, how does this fit into the ACA? Largely, when we're dealing with the employer-based health insurance, we're still working in an experience rating system. For the state-based marketplaces, there's a modified form of the community rating system. So for each type of plan, premiums are allowed to vary by family status, geography within a state, smoking status, and age. But they cannot vary based on gender or health status. So this is where we get into the pre-existing condition stuff, and I'm going to talk about that a little bit more detail in a minute. I do just want to say, you may wonder, why is gender here? And that's because, in general, women or people with uteruses, to be more inclusive, tend to have higher costs because of pregnancy-related care, essentially, right, throughout their lifetime. But you cannot vary based on those facts. So we've already established that the people who are accessing care on these marketplaces are a really small portion of the overall privately insured space. And largely, they are likely to either be kind of younger people or people who are sickly and cannot work, right? That's why they cannot get access to work, or are in a situation where they don't have access to work, which may have other related issues. So, in general, you can imagine that it is kind of a sicker pool to begin with, and you end up with this issue in community rating systems of this economic concept known as adverse selection, which in the case of insurance means it's the tendency of those in dangerous jobs or in high-risk lifestyles or with worth health situations to get health insurance. Okay, so they are more likely to buy into health insurance than somebody who doesn't feel that they need it, right? If I am 25 years old, I maybe go to the doctor once a year, I'm healthy, why would I spend money on health insurance, right? Like that's the mindset. And so what ends up happening then, if you have this you have this system of these exchanges where only really the sicker people are opting in, you're going to end up with higher premiums for everybody. Okay, does that make sense? Hopefully that makes sense. So how do you deal with that? I'm going to talk about that in a second. But before I do, I just want to spend a minute to talk a little bit more about pre-existing conditions. So one of the provisions within the ACA is this idea of guaranteed issue, which is that people who get health insurance on their own, so again, people using these state exchanges, cannot be turned down because of any pre-existing condition that they have. This was not the case before the ACA. It was a very common thing for people, if you had to buy health insurance on your own for any reason, like if you owned your own business, you're an independent contractor, employee didn't offer it, you were unemployed, you could be rejected by the health insurance company for conditions as common as asthma or high blood pressure. One thing that was very common for a little while was folks who were like transgender individuals or gender nonconforming individuals who identified themselves as such in their insurance applications would be denied based on pre-existing conditions. So that was a huge issue because these are things that cost money to insurers, right? So why would they want to take you on in their care? So they can no longer deny you on these things. And this has a huge impact. I mean, a 2011 study by the Department of Health and Human Services found that the number of people with pre-existing conditions across the U.S. is likely between 50 million and 129 million non-elderly Americans, which is a wide range. But even if you're looking at the lower end of this, 50 million people, that's 1 out of 5 Americans under 65, including 25 million who are uninsured, right? So it's a huge number of people who are impacted by this. Okay, so now you have all these people who can now access insurance, and it is awesome. But how do you pay for this, right? Like, what is the issue? How do you make it so premiums across these markets aren't incredibly high? Well, here we're going to introduce one of the most controversial parts of the ACA, and that is the individual mandate. The individual mandate requires that individuals have some form of health insurance, what we call minimum essential coverage for themselves and their dependents. There's some caveats, exemptions to the mandate and financial assistance and various things. But in general, people have to have health insurance. Individuals who do not maintain health insurance at this minimum level have to pay a penalty for each month of noncompliance with the mandate. And the penalty is always the greater of a flat dollar amount or a percentage of their applicable income. The amount of which has changed year to year. It's gotten bigger. I have a cool infographic in my notes here that Mr. Hank can share with you if you're interested in the actual numbers, but basically know that you have to pay money, you have to pay a financial penalty if you decide to not have health insurance. And so let's think about how these things are connected, right? So again, when we think about the pool of people who kind of fit in this realm of people who would be using these marketplaces, they're generally either people who are sick or have issues that prevent them from getting employment, or younger people. So you really want to bring in those younger people, right? Because if we think about the spread of care across all of these people and the money they're putting into it, if you bring in more young people, you're going to expand this insurance pool. And you're going to make it so you're going to bring those premiums down because the cost of the care for those younger people is a lot less. So you may remember, you may not, I don't know, but every year, and especially at the beginning, President Obama spent a lot of time going on random shows and things that really were targeted towards 20-somethings and talking about the ACA. And sure, I mean, there's this whole thing of like, yep, health insurance is great and it's good for all of us, da da da. It had this message. But the reason why he targeted that population in particular is to really make these marketplaces work in a way that is sustainable. And hopefully that makes sense. So, the question is, will they buy it? Does this work? And critics even at the time were skeptical. I mean, I guess that's the nature of critics, right? That many young people would take the penalty. They just opt for the penalty until they are sick because likely it would cost them less money. And why would I buy this thing I don't need? and unless these young people join these pools, the premiums are going to raise sharply for everyone else. So what are we seeing? You may have heard through these last series of debates, Donald Trump talked about how insurance premiums were skyrocketing, quadrupling, all of these things, which was hyperbole, but there is a grain of truth to it. We have seen that not as many young people have opted in as was anticipated in this system, and so premiums are raising. Subsidies as well by the federal government are also raising to kind of supplement that, right, and to kind of handle that, but how sustainable is that? And that's the big question, and this is really where a lot of the concern comes up. There's also folks who on the right who believe in a true like market system that people should have the right to not have health insurance. And this really comes in is a philosophical issue, right? Do you believe that health insurance is a right or a privilege? Do you believe that it is something that you have a choice for or something that you need to have? That's a conversation we're not going into, but it's worth considering. So that's where we're at with private insurance. That was a lot. I do just want to say one last thing. This president-elect originally did talk about, through his campaign, this idea of repealing and replacing the ACA. He wanted to get rid of the whole thing. However, in the last week or so, he has come out as saying that he's pro keeping in the guaranteed issue, right, this pre-existing condition clause of the ACA, as well as coverage of youth to 26-year-olds. And it's funny because it just shows that, like a lot of Americans, unfortunately, there's the lack of understanding of how this market works. How are you supposed to keep the guaranteed issue clause without the individual mandate? It doesn't work. The whole system collapses. So we're going to see where that goes. But this is the situation. It seems that a lot of people just don't understand how this works. Okay, so now we're going to move on to Medicaid. This is going to be a little bit more straightforward. So Medicaid and Medicare, the public insurance that we have in this country, were created under the Social Security Amendments of 1965. So Medicare is health insurance coverage for elderly adults, 65 and older, and some folks with disability. I'm not going to talk about Medicare. There are ACA impacts on Medicare. Medicare is convoluted. We don't have time to go into it, and it's less controversial, to be honest. So we're going to talk about Medicaid, which is coverage for certain low-income populations, as well as some other populations with disability. So under this program, the federal government provides matching funds to states to enable them to provide medical assistance to residents who meet the eligibility requirements. So there are matched funds from the state and the feds, right, that come together to be able to fund health insurance for low-income people. So what are these eligibility requirements? Well, prior to the ACA, the floor that was set by the feds included only certain components, certain populations within these low-income individuals. For a while, it was folks at 100% of poverty. I believe it raised up to 133 at a certain point, but it only included children, their parents, pregnant women, the elderly, or individuals with disabilities. So in most states, adults without dependent children were completely ineligible for Medicaid. All right, so they never had access to it, regardless of their income. And for parents, the income limits were very low, often below half the poverty level. So we're talking very, very low. Federal poverty level, for reference, this year, as of 2016, the federal poverty level for an individual is set at $12,000 for the year. Like, you're taking home only $12,000 for the year. How anyone lives on that, I have no idea. And so that's what we're talking, right? So parents could only, for example, qualify if they made $6,000 for the entire year. Right. So the Medicaid expansion concept, what the ACA did is it said, as the law was written, that states were required to allow people with income up to 138% of poverty, which is still quite low, right? We're talking around $16,000 for the year for an individual. But those folks were qualified for coverage, including adults without dependent children. This is the key thing here. That is the group that is benefiting the most. There's some other changes. I do have some infographics that kind of show how these different groups were impacted, but really that's the group that impacted the most. So to make this happen, the federal government would pay 100% of defined costs for certain newly eligible Medicaid beneficiaries, such as these adults without dependents, but that would decrease to 90% over time. So eventually the states would take on some of those costs. And as written in the law, states that did not comply, that refused to enact this expansion, would lose all of their federal Medicaid funding. So, as you are probably very aware, the ACA since the beginning has been very controversial, and there have been kind of legal actions that have impacted how the ACA is rolled out. And this is one of those areas. So there was a Supreme Court case called National Federation of Independent Business versus Sebelius. Sebelius is Kathleen Sebelius, who was the head of the Department of Health and Human Services at the time. And it had two components. It was challenging the constitutionality of the individual mandate, which we just talked about, which it upheld, largely for a lot of the reasons we talked about. I'm not going to go into that. And secondarily, it challenged this mandate on the states for this Medicaid expansion. And for that, it found that this expansion mandate was coercive to the states because states did not have adequate notice to voluntarily consent to this change in the Medicaid program, and all of the states' existing federal Medicaid funds were potentially at risk, right? So they had no preparation, they weren't consulted, and now they could be losing all of their Medicaid funds, and that was a coercive situation as far as the Supreme Court was as far as they found, right? So now the way it actually went into practice, the way it works is now states could legally opt out of the expansion. It was a completely optional thing. And currently in the US, 32 states have opted in and 19 states have opted out. I've included in my notes a map that Mr. Henning can show you of what states we're talking about. And unfortunately, the states that opted out are largely the states with large segments of their population that are really living under poverty and could really benefit from this expansion. So it's really unfortunate. And in fact, I have a second infographic that kind of shows how many people in each state would benefit from this expansion. So that's a problem. And if you actually look at the map, you'll probably also notice that these states, largely in the Deep South, as well as that kind of agricultural belt in the middle of the country, are also kind of those Republican strongholds now, the people that voted for Trump. And this has, been a tension for a long time, and hopefully you all have talked about this switch of these states supporting the Republicans and the Southern strategy and all of this stuff. Clearly we're not going to talk about it in this talk, but it's something that's really interesting to consider, right? So in terms of the future of this Medicaid expansion, it's unclear. I honestly haven't heard a lot about it. It hasn't really been talked about with the president-elect. However, it is very easy to imagine that it could be gutted. In particular, right, the way that this works is for states that have accepted this expansion, the federal government is paying for a lot of it. And there could be amendments passed, even if they don't get rid of the entire ACA, that say we're not paying for this anymore. And if that happens, well, states aren't going to be able to continue. A lot of states, anyway, are not going to be able to afford to have this expansion in place. So we'll see what happens. I think it is something that is, unfortunately, there's a likelihood that it could go. So those are the kind of big things, right? We talked about private insurance, public insurance. This is where we're at. I do just want to spend just 5 minutes at the end here to talk about a couple of other parts of the ACA that are likely going to come under attack and that people are very concerned about and that matter to me. And from what I understand about you all, likely will matter to you as well. So the first thing I want to talk about is the Women's Preventive Health Amendment. So one of the cool things in the ACA is this idea of essential benefits. So prior to the ACA, insurance companies could make calls on what they included in their coverage, what was actually covered under your health insurance. And it could vary widely. But the ACA defined these things called essential benefits, which standardized key coverage, focusing on necessary acute care and preventive care. And so all plans offered in the United States had to cover these services. Now there could be cost sharing, right? Like they didn't have to fully pay for it, didn't have to fully come out of the insurance company's money. There could be deductibles, copays, whatever. but essential benefits had to be included with some degree of coverage. So this included things like ambulatory services, emergency services, hospitalizations, pregnancy and maternity care, prescription drugs, and preventive services. So essential benefits are a thing. Within that are these things that are considered preventive services. So these are things like healthcare screenings and physicals, things like that, that are things that are kind of wellness things to catch health problems early and to avoid acute care. And the rationale behind this is, and these things, excuse me, let me back up. Preventive services must be covered and offered free of cost to the individual. So there's no out-of-pocket cost for the individual who is trying to access preventive services. And the rationale for this is, as we've seen both domestically and in other countries, that when the bulk of the population are accessing preventive services, the overall net healthcare costs drop because you're not ending up with more advanced health problems that cost more money to treat. Makes sense. So we have the essential benefits that have to be covered. You have preventive services that have to be covered free of cost. And within that is this thing, the Women's Preventive Health Amendment. So the idea for this was introduced by Barbara Mikulski from Maryland, one of my senators, as this thing. Like, we need to figure out what works for women. And I'm just going to side note say that really these things impact people with uteruses, whether they identify as women or not is kind of irrelevant. That's just what they call it. So to put this together, to figure out what was actually appropriate to fit under this Women's Preventive Health Amendment, Congress actually called on the Institute of Medicine, which is an independent, non-governmental organization that brings together experts in their fields to make recommendations about health. That's what they do. So a group of experts came together and put together a list of things that they recommended should be covered under this preventive health umbrella for women. And this included things like breastfeeding support and counseling, breast cancer and cervical cancer screening, UTI screening, and possibly one of the most controversial things in the ACA, full coverage of contraception, birth control. As you are likely aware, lots of folks are very unhappy about this. It actually led to a Supreme Court case, the Hobby Lobby case, which I would love to talk to you about, but there's no time to. And there's been some impacts there, right? But what is important to understand is there is data to support that this really is preventive health, and that a group of experts considered contraception to be under this umbrella. And I wish I had time to talk to you about why, but just know this is a thing. But particularly the evangelical right has not been happy with this. So likely, I think anyway, under the new administration, as well as this Republican-controlled Congress, the contraceptive coverage mandate and possibly all of the Women's Preventive Health Amendment will be removed from the ACA. And unfortunately, like most of these things, the people who are likely to suffer are largely low-income women or people with uteruses. My coverage, my access is going to continue, right? But it's the people who struggled to get that access prior are going to struggle again. We have plenty of data about how the contraceptive coverage mandate has led to a lot of really positive health indicators, but we'll see what happens. So that's one thing. The last thing I want to talk about, and I'll do this very briefly, is Rule 1557, which is a directive within the ACA, often referred to as the non-discrimination provision. The law prohibits discrimination on the basis of race, color, national origin, sex, age, or disability in certain health programs or activities. So it's an extension of kind of these civil rights protections that we have in general in the US. In terms of what falls under sex, has been teased out. And as of May of last year, the final rule actually prohibits the denial of health care or health coverage based on individual sex, including discrimination based on pregnancy, gender identity and sex stereotyping. Now, there's still some work trying to, advocates are still trying to get sex stereotyping to be more explicitly about sexual orientation. There's a precedent that sex stereotyping has been used to cover sexual orientation. It's largely used that way, but it's meant to be, they want it to be more explicit. Regardless, gender identity is considered under this protection here. The final rule also requires that covered health programs and activities treat individuals consistent with their gender identity. So there's a wide umbrella of non-discrimination protections for people regardless of their gender identity. This includes transgender individuals and gender nonconforming people, right? And unfortunately, I have lots of data on this. If you're interested, I'd be happy to share. There is a long history and a lot of data about discrimination of trans-identified folks in healthcare settings and with health insurers. So this was a protection in place that actually there are ways where you can follow up and report if you've been discriminated against. There are actual actionable things and accountability that comes with this. A lot of people in my professional circle as well as in my personal circle are quite concerned that if the ACA is overturned, one of the things that's going to be overturned is this Rule 1557, and those protections will be gone. And the health insurance, the ability to access health insurance and health care that is appropriate and without discrimination for trans-identified folks will be gone. So who knows what'll happen? We'll have to see. It's clearly, this whole law is, the whole of the ACA is very controversial, as we've kind of discussed. And yeah, we'll see what happens. I hope that was interesting. I hope that was clear and useful. If you have any questions, you can ask Mr. Henning, and he can share that with me. And I'd be happy to talk in more depth about anything. I'm also happy to cover other topics. Mr. Henning and I kind of talked about that you might all be interested in learning a little bit more about the legal history around contraception and abortion and gay marriage, which are all related legally, and kind of what we're expecting might be issues and what things are kind of safe moving forward with what's going on with the courts and the new administration. So if that's something you're interested in, I'd be happy to talk about that as well, or anything else that falls within my expertise, I would be happy to talk to you about. So hopefully that's helpful, and good luck with the rest of your studies.